Go ahead.
My name's Thomas Beale. I work a lot on something called Open EHR. I haven't worked in C3-Cloud. My colleague Ron Chen from Cambridge was going to present afterwards has. So I've been asked to just provide a few outside perspectives on CDS, planning, guideline, that sort of thing. So it's only 15 minutes, so I'll be very quick. That's who I am. Very quickly, I'm on the engineering background side. I'm not an MD or anything like that, in case anybody cares about that distinction. So I thought I'd just start with a few interesting questions in this whole CDS and clinical process kind of area. One of them is, what's going on with my patient? Patients visit medical facilities and they get their care from quite often multiple places. As they go through these facilities, data gets recorded in dozens of systems, the standard data silos problem that everybody knows about. And we have very weak notifications and coordination between people working in their separate places. So the expectation would be of seamless care. That's what the patient wants. It would be a bit like getting your tax accounts done by 5 different accountants, each working in different firms and doing a few pages each and not really able to talk to each other. So it's kind of crazy what we do in healthcare. So the situation today is that there's increasing team-based and distributed care. We have long-term routine monitoring, which is more based on protocols and plans rather than just ad hoc care. There's lots of things that take some days or weeks in most inpatient hospital visits. Chemotherapy is a good example of something that takes multiple weeks, which I'll just show an example of later. When things take time and when there are a lot of people involved in different places, you've got constant shift and personnel changes on the health professional side. So the question is, who knows what's happening with the patient? And the answer is nobody, no person. The EHR as a tool, if you had a good quality system in a passive way, knows everything. And the planning system, if you have one, it can potentially know about what's going on with the patient in an active way. Question 2, how to get from care pathway PDS to some sort of clinical, computer represented clinical practice guidelines or pathways. So this is the question about formalizing things that are currently typically available as published, well, it's a PDS, that could be HTML or whatever. This guideline you're looking at here is Intermountain Healthcare Emergency Management of Acute Ischemic Stroke. It's an 18-page guideline. Just have a look at the density of information in here. There are little algorithms. In that 3-column table on the bottom left, you can see essentially different types of tasks for different types of people who are involved in this time-critical care. Elsewhere in the guideline, there's another little algorithm there. You can see that the density of information and details. It's quite clear that even the most wonderful clinician wouldn't be able to memorize all of this, and that's one of the reasons it keeps changing. So we need computerization of this. So one of the questions is it's not a question that we need it. The question is how, and you have to think about what is the formalization of all of these kinds of information, tasks, decision trees, and so on. In here, a lot of conditions and fragments of logic and so on. How do we formalize it? In that guideline, there are 7 identified types of people doing the work roughly in parallel. So the question there is about how to coordinate those people across different bits of the hospital. Okay, the formalism challenge, I'm just going to summarize as guidelines today are complicated, particularly care pathways. That's the bigger thing. So care pathways is a picture of care to achieve a goal for a patient, for example, stabilized sepsis, and guidelines tend to be the pieces inside, so probably should really say care pathways there. They keep changing, so we need formalisms that can represent things like tasks, events, time, and conditionality, but we've also got to be able to state how the logic part and the plan part are connected to the EMR or EHR, whatever you've got in the background. The decision, so there's a decision logic part. First, tasks and events, that's basically about doing, right? That's activities, tasks, that's sort of a BPM kind of area idea. Decision logic is about you can think of it as potentially clinical programming. So this is more like the Arden area. And the third thing is you've got to solve is what I call subject variables. In other words, the patient data items. It could be as simple as blood pressure. It could be the fact of them being diabetic or not, and so on. Here's a beautiful screen of a CDS system. So question 3 is, how can we integrate CDS into the EMR? And we have a form here. It's in Swedish, and my Swedish is not very good, but it's Sociocoma scale. You've got some vital signs on the bottom left, and you've got the input variables, I think, in the middle, and the results on the right-hand side. You can see recommendations on the right. So CDS, if it's running and doing, you've got a CDS module that's applicable to your patient, it can be very nice. These screens, by the way, from Rong's company, Cambio. That's Chad Vask, so that's a stroke risk analysis guideline. Great, isn't it? It can feel like you're in heaven with these things because you've got a very clinical level view. There's no junk on there. It's the clinician's view of what's going on with the patient if they're seeing some patient variables, plus any algorithms. And that's where we'd like to be, or that's where clinicians would like to be. The problem is getting the data. As everybody knows, this is what the reality of the back-end problem looks like. We always use the word silos to sort of represent the horror story. Some of them might not be so recent even, and that happens a lot in large places. Maybe some of them are made by open source people with access to very good quality drugs, so they're painted. However, they're all different, and that's the problem, and sometimes it feels like you're in hell. So that's the back-end problem. So the difficulty of EMR integration problem has made people think that it's just a data access problem to be solved by standards. Now, it definitely is a data access problem. There's no doubt that there's a big problem there. But we are seeing it as a question of lifting epistemic data, that is facts, partial data sets, bits and pieces known by back-end systems, to populate ONTIC subject variables. So ONTIC just means reality grounded. In other words, the actual blood pressure or the actual diabetic status of the real patient in the world. So we would like to be able to have variables that we could use inside our guidelines of care pathways, like is diabetic, or neutrophils, or SpO2. Now, there are other problems that I'm sure everybody here knows very well. The question of how does a system pick the right guideline at the right moment? There are tricks there. You can use catch events. You can match preconditions to make sure that, for example, a guideline that only applies to a pregnant woman or a person who has lymphoma, that precondition has to be true before the guideline would execute. You also have to do things like preventing useless alerts, and there's lots of tricks in that area as well. I'm not going to talk about them. I'm just going to point out that these are the kinds of areas or things that have to be dealt with. Obviously, you don't want this kind of thing happening on your screen when you're dealing with sepsis. Now, a naively designed system, you could sort of imagine, maybe not quite going that crazy, but it can get out of control because everything looks like an alert if you've got a sepsis patient who's slipping away. But that result is obviously of no help whatsoever. It's just going to probably end up killing the patient. Question 4, problem of cognitive integration. So medicine is a cognitive thing. When people are doing clinical work with patients, they're working in their mind, and there's the patient, there might be instruments and so on. We have to remember what we're trying to do here. So if we want to put in plan, guideline, CDS kind of systems, you can imagine it's like that Waze navigation system you see there, but we have to remember one key thing. The primary actor is still the physicians, and that's the driver in this case, and this guy here is the help. So he's not going to do all the work for you. It's actually something more like a co-pilot, which is helping the primary actors, that is the physicians and nurses and everybody else, do their work, but in a more coordinated way. In the cognitive area, there's obviously questions of attention and focus, and systems, again, badly designed systems, and that's probably most systems all of us have ever built to date, compete with the focus of the work, which is the patient. Now, it's interesting, this isn't really my area of expertise, but I've talked to people who do work in this area. Patient work is substantially eyes and hands. Why not talk to the system? And Catherine Kranacki mentioned just a couple of talks ago, voice control. I've worked in a project for the last 3 years at Intermountain Healthcare in the US, and they have voice control working. And the effect is something like, imagine if you were in an obstetric situation, the obstetrician could say, "Hey Alexa, patient hemorrhage, switch to cesarean protocol." Now I've seen that working. We don't use Alexa, I just use the pretty picture of Alexa, but it's the same concept. So you have to use some tricks like think about voice control seriously as a part of the solution for the cognition thing. So let's just have a look at the solution side of things. The general need, adaptive process plan-based system, plans formally derived from care pathway guidelines, integrated analytic guidelines, that's the kind of thing that Rom's going to talk about, EHR backbone, solution for subject variables, so a new category of system. So the main thing I'll talk about quickly, probably my time's getting close to the end, is just the separation of concerns. Plans, that means having formalism for representing plans, that's the pink thing at the top. A formalism for decision logic modules, well, that's how we call them, but that's the logic part, and that's something like clinical programming on the right-hand side, the green part. And then there's the big mess of the patient data and pulling it up from the back-end systems. So this separation is the key to success, or at least any possibility of success. So as I mentioned before, the problem of the patient variables and data is there's just an interminable list of annoying things that take forever to solve, different types of conversions and standards and so on. So a very just brief outline of our view is the question of going from epistemic data, what's just scattered around the available systems, into what you want to use as variables inside a system, is partly a technical question of pulling these data up from the back end. You might have to look in various back ends. You need to separate out this whole problem from the guidelines and from the decision support and the plan representation. That's one of the mistakes that's been made in the past, is to try and build in the problem, even the simple well-known problem of having to ask the doc on the screen, can you tell me the patient blood pressure or whether they're taking beta blockers, when they can't find, when the system can't find it in the EHR. So separating this out is a key part of solving this problem in a slightly better way. And I'll just take another 30 seconds to just quickly show what a real version of that looks like. So that's a thing called CHOPS, which is a kind of chemotherapy protocol for lymphoma. You can see, for example, there's a box there. These are tasks. Administer doxorubicin, coming from the decision support module, and the value doxorubicin dose. Here's a decision support module. That's a whole lot of logic there. There's variable definitions there, and you'll see here doxorubicin dose. It's a quantity, and there's a calculation there. Now, although it looks like programming, if you were to spend a bit of time, which obviously you won't do now, you would see how closely it reflects what is in the NHS guideline from which this was taken. And we don't have the time to go through that in detail, but the idea is to get very close to a programming language. And now you can use tools to hide the entire language. So the idea isn't to force clinical designers to become programmers, but some like using languages. So that's the area we're exploring. Last slide, just a very quick list of standards activities. I don't really have the time to go into any of this, but the kind of big areas, I guess, are ones that I think people here are all familiar with. One of the big guys on the block is the BPM plus activity. It's a kind of combination of a whole lot of BPM and related standards from OMG. So you'll be familiar with BPM workflow. DMN is decisions, so that's the logic part in terms of OMG standards. There's a whole lot of stuff in HR7. I've just put some resources on the screen in case, I guess probably most people do know where these things are, but it's just to provide the links. So that's it from me. Thanks for your attention. Hope that was useful.